Welcome to Onc Now. Today we're joined by Professor Simon Lord, and I'm your host, Dr. Jonathan Sackier. Simon is a leading figure in cancer research and early-phase clinical trials. The good professor is an honorary consultant in medical oncology and associate professor in experimental cancer therapeutics at the University of Oxford. He works at the cutting edge of cancer drug development in the early-phase clinical trials unit, where his focus is on translating scientific breakthroughs into real-world treatments. With deep expertise in precision medicine and a passion for innovation in oncology, Professor Lord brings a unique perspective on how the future of cancer therapy is being shaped today. So it's with great pleasure that we welcome Professor Simon Lord to Onc Now podcast. So, Dr. Simon Lord, real pleasure to have you here with us today.
Well, thank you for the invitation.
You're welcome. So we're going to start off with some quick-fire questions to kind of ease our way into this. You've led cutting-edge research in early-phase oncology trials. What initially took your focus onto breast cancer?
So, well, I actually came down to Oxford to pursue a DPhil or PhD, as it's called anywhere else except for Oxford, with a mentor called Adrian Harris. He used to lead the medical oncology unit here, and that was a project to try and understand how metformin might alter breast cancer metabolism, and that's led me to have a continued interest in breast cancer research, in particular in the context of cancer metabolism.
Okay, well, we're going to dig into some of that in due course. You're deeply involved in experimental therapeutics. What's one thing the public, and in fact many doctors, misunderstand about cancer drug development? Maybe give us a 30,000-foot view.
Well, perhaps if we can focus on patients, I think that there's often some frustration. I would say in the medical community as well, with regards to the length of time it takes to get sort of the concept of a therapeutic strategy all the way into the clinic. A decade would not be uncommon, and longer. And also the immense amount of money that it takes, which fundamentally leads to high drug costs once drugs are delivered into the clinic. And that is a continued problem. I don't think it's getting any better. It's possible that artificial intelligence approaches might improve timelines and reduce cost, but we're still a bit of a way from that.
So, yeah, you're absolutely right. I think people underestimate the amount of time it takes, the amount of money it costs, the problems in doing clinical trials, and the thought that AI might allow us to have avatar-type controls, maybe, that sort of thing. Is that where you're going with that?
Well, I think there's artificial intelligence might have two roles here that I can think of offhand. One is that in terms of selecting targets more quickly and developing molecules. And the second thing is whether we can start to introduce more automated processes in terms of regulatory and also particularly trial monitoring, which is an incredibly costly part of delivering clinical trials.
Yeah, very much so. How do you see imaging evolving in the next decade of in cancer care?
Yeah, so I think imaging one area that I think that there's a lot of interest in terms of drug development is theranostics. And I essentially targeted radiotherapy delivery, if I can put it that way. And one of the advantages of that approach is that you can use your agent to also select patients based on imaging. So obviously we're always worried about the heterogeneity of cancer, but if you can image all the areas of cancer in the body and get a determination of the expression of your target of interest, and then deliver your radioactivity via a targeted approach and selected patients with the same age, and that's very attractive.
Right. So,
if I give one example, I think there are other examples, but that's one that I'd like to pinpoint.
All right. Okay. I mean, I just think how your specialty has changed since I graduated, where imaging was basically mammography, and that was it, with all its drawbacks. You've trained and worked across several prestigious academic centres. Was one piece of advice that's stuck with you over the years, and of course now working at Oxford?
Yeah, I think one I think that serendipity maybe doesn't play a part in everyone's career, but in my case, it certainly has. And I think I've always, it's not just one person has advised me of this, but I think taking opportunities and looking for them is very important in terms of developing your career. And you often end up in places and currently and participating in projects that or possibly working in centres that you didn't initially expect to. And that's certainly from my perspective, that's played a big part in my career. If I was talking to it, so that's a piece of advice that I've certainly passed on to academic medical oncology or budding academic medical oncologists.
Go with the flow, right?
Yeah, well, not exactly. I think you have to choose. You have to choose your opportunities, but I don't think you can fully plan your career out when you're in your 20s or even early 30s, or probably later on as well.
A rock musician friend of mine said it's astonishing. The harder I work, the luckier I get. Right.
So I think that's true. I think, yeah, if you deliver on projects, funnily enough, other stuff winds its way to you.
Yeah, absolutely. So we'll now try a sort of a quick fire round, if you will. First thing that comes into your head, you've already kind of touched on this. Will AI dramatically accelerate oncology drug development? Let's just go to the molecule identification. Yeah.
Yes, I believe so. I think we're already seeing that, actually.
Yeah. Or maybe that will shave. I think the average for drug development years ago was 11.6 years from identifying the molecule for the first patient being treated in the clinic. So, yeah, 10 years, it's a long time. Is metabolic imaging going to be a major part of precision medicine?
It's already an important part of precision medicine, particularly dynamic response, which I think we often forget about. For example, in the context of lymphoma. So I think it's already a major part of precision medicine.
Right. Is insulin resistance currently under-addressed in breast cancer care?
Probably. Certainly there needs to be more research in that area. And, with the obesity epidemic, we are seeing growing interest from funders. And so I think we'll learn a lot more about therapeutic strategies in that context.
So with the wide use of GLP-1 drugs, are we going to see a reduction in cancer in years to come?
That is a very interesting question.
That's why
we're already so it's not. It has come to my mind as well. So we're already seeing, but I think particularly in the US, we're already seeing obesity rates decline quite remarkably just in the last obesity prevalence, I should put it like that, in the last 2 or 3 years. So whether that will feed through to reduced cancer incidence, well, I think that there's a reasonable chance of that, and of course other obesity related diseases as well.
Yeah, other like hips being done, knees. As a surgeon, I was interested to see the impact. And in the last few years, the number of bariatric procedures it's coming way down, way down. No surprises there. Should breast cancer screening guidelines evolve to better account for metabolic risk?
Not in that. Well, we developed some prognostic models that potentially would be applicable to breast cancer screening. And whilst we didn't have data for insulin resistance, type 2 diabetes didn't seem to impact in those population-based models. So not from our data at the moment, anyway.
Okay. Can early phase trials become as patient-centered as later stage studies?
Well, I think they certainly should be, and certainly in our unit, we make sure that we have but have a patient-centered approach. For example, we have a dedicated palliative care support for patients on early phase clinical trials, and also linking closely with our psycho-oncology team as well. So I don't see why it should be any different.
Okay. So let's shift gears and sort of dive in a wee bit deeper. So you've led a number of trials focusing on novel imaging techniques, which we hinted at. We mentioned metabolic imaging. Can you give us a quick definition for those unfamiliar and walk us through how it's helping us better understand breast cancer tumor biology?
Yeah, so metabolic imaging essentially exploits the fact that cancers tend to have sort of differential metabolic signature compared to background normal tissues. Probably the best example, well, not probably the best example of this, or best known example of this is 18-fluorodeoxyglucose PET-CT, or 18-FDG PET-CT as it's often called. So we know that many cancers, not all, take up a lot of glucose, essentially for their anabolic requirements, in particular, rather than energy. You can therefore look to image that glucose uptake using this technology. So 18-FDG is a sort of synthetic analog of glucose that's been tagged with radioactivity. And by combining structural imaging with a CT scan and with a PET scan, which can detect the uptake of this radio tracer, you can get a lot more information about the character of your tumor. And that's used very routinely now in breast cancer treatment, firstly to stage patients to determine operability, and also perhaps assess where you should be delivering any radiotherapy, but also has great utility in determining treatment response. So we'll often see a change, well, we not often, but pretty much always we'll see a change in the metabolic response earlier than we'll see any change in the structure of the cancer, for example, or i.e. shrinkage of the cancer. And that can be useful both in the standard of care clinic, but also in drug development, because so PET-CT is not uncommonly used to assess for potential activity of your drug in early phase clinical trials. Now, more specifically, in terms of particularly in the research setting, we're very interested in understanding how imaging signatures, metabolic signatures, might reflect tumor biology, as you described in your question. And in these studies, we will typically take tumor samples alongside our imaging, and then try and look to match tissue-based assays, for example, transcriptomics, metabolomic profiling, or immunohistochemistry, to the imaging signature to better understand what how that metabolic signature might reflect tumor biology.
Excellent. So we hinted at this in our opening questions, insulin resistance and its role in breast cancer. How does insulin signaling and metabolic dysfunction impact disease progression or treatment resistance?
So that's an active area of research interest for us, and perhaps I could specifically talk about estrogen receptor positive breast cancer. We already know that PI3K/mTOR signaling is important as a resistance mechanism to endocrine therapy in estrogen receptor positive breast cancer. There's a lot of crosstalk between estrogen receptor signaling and the PI3K/mTOR pathway. And indeed, we use PI3K inhibitors and mTOR inhibitors routinely in the clinic now, in combination with hormonal therapy. But we also, it is the case that the insulin receptor lies upstream of the PI3K/mTOR pathway. And so higher insulin levels and greater input into the insulin receptor will lead to increased PI3K/mTOR activity and therefore potentially resistance to hormonal therapy in breast cancer. And indeed, there's quite a lot of preclinical data now to suggest from animal models that if you have greater insulin, higher insulin levels, that can lead to resistance to hormonal therapy, but also if you introduce therapeutic strategies such as fasting strategies in these animal models, you can augment the effect of hormonal therapy. Now, we still need to learn more about that in the clinic, and that's an active area of research for us. But the long-term view would be that there is potential, perhaps in selected patients, so maybe those with a history of insulin resistance or obesity, to implement therapeutic strategies such as fasting or maybe drug intervention, such as perhaps an SGLT2 inhibitor or other, to improve outcomes for women taking hormonal therapy for estrogen receptor positive breast cancer.
So you've mentioned hormonal therapy, and they've long been a foundation of breast cancer treatment. I'm old enough to remember the early days of Tamoxifen. Where do you see the biggest opportunities for improving how we tailor these treatments based on patient-specific biology?
Yeah, so I think that we've already seen, of course, some real steps forward in the treatment of estrogen receptor positive breast cancer in the last number of years, in particular with the introduction of CDK4/6 inhibitors. But both in early disease and also advanced disease. In the drug development community, or particularly the breast cancer drug development community, there's a lot of interest in developing new CDK inhibitors. For example, in particular, CDK4 inhibitors, which seem in early phase clinical trials to have a much better toxicity profile, specifically hematological toxicity, which means you can probably dial up the dose of these drugs for better therapeutic effect. Alongside these drugs, alongside the new CDK4 inhibitors, which may take over from CDK4/6 inhibitors in first-line disease, will be an interesting area to look at. It may be that perhaps in patients that have biomarkers of resistance to CDK4 or CDK4/6 inhibitors, but other classes of CDK inhibitors will be useful in combination. Particularly, I'm thinking of CDK2 inhibitors, which are also going into early phase clinical trials at the moment. And there it may be that, certainly from the preclinical data, that biomarkers of CDK2 activity or cyclin E activity will be important in selecting patients for those sorts of combination treatments. And potentially they may have potential both in advanced and again early disease.
Okay. So, sort of follow-on question about tamoxifen. I remember there being a black box warning for uterine sarcoma. What's the latest on this? I haven't sort of followed that. How much of a risk is it?
Yeah, well, certainly we know that there's a significant risk of endometrial cancer with tamoxifen, and that seems to be related to there's evidence that that's linked to how long you're on tamoxifen, potentially the dose you give, and is mostly relevant really to postmenopausal women. And I think studies have suggested that the risk, if you look at age-matched controls, is about 2 to 3 times the risk of the general population. Uterine sarcoma is much rarer tumor type. I can't say we see it commonly at all in the breast cancer clinic. There have been some studies that have suggested a link. I think because of its rarity, there is still some uncertainty there.
Okay. Yeah, I remember when that first came out, there had been about 150 cases globally, I believe, but obviously still a drug that's used. What's the current thinking about combining metabolic interventions like insulin sensitizing agents with standard breast cancer therapies?
Yeah, so I don't, there's not strong clinical data to do in terms of specific approaches in the context of breast cancer care at the moment. Certainly no randomized data. But clearly, it's important that patients who have evidence of insulin resistance are properly treated and advised in primary care or by their endocrinology and diabetes teams. I think the one exception to that is in the context of PI3K and mTOR inhibitors. So particularly PI3K inhibitors, where we very routinely see hyperglycemia as a toxicity. Over 50% of patients will develop hyperglycemia with these drugs. And so we would routinely, and these drugs are always given in combination with hormonal therapy in the context of estrogen receptor positive breast cancer in the breast cancer clinic. And so we would routinely monitor from baseline for changes in glucose levels, HbA1c. There is actually some quite compelling preclinical data to suggest that hyperglycemia or reactive hyperglycemia in the context of a PI3K inhibitor it may be a resistance mechanism to hormonal therapy. No, sorry, not hormonal therapy, resistance mechanism specifically to PI3K inhibitors. Again, probably due to increased insulin levels and greater input into the insulin reception, thus development of PI3K activity, PI3K mTOR signaling activity. And so there's a good rationale to make sure you're very tight on glucose control. So we will routinely, if there's any evidence of hyperglycemia, put patients on mTOR inhibitors or SGLT2 inhibitors for these patients. In fact, it's the latter drugs that we've seen tutors here particularly effective for hyperglycemia in this context.
Okay. Well, thank you for that. I want to change tack a little bit, Simon. Many breast cancer patients are highly motivated to make lifestyle changes, and there's a lot of discussion nowadays about lifestyle changes, but what are the real perceived or questionable benefits of such modifications, and are we doing enough in the clinical setting to support and personalize such interventions? And maybe start by a couple of examples of these.
Well, certainly we know that there's lots of data linking normal body weight and regular exercise from many studies, not just breast cancer studies, but other studies to better outcome. And in fact, there's been some randomized data discussed recently as COVID, and is the context of colorectal cancer specifically, that has shown good evidence, for example, that exercise is important in improving outcomes. Do we do enough in the clinic? Well, I'm certain not. I think obviously we feel there's so many other priorities that we have in a busy medical oncology clinic that those sorts of interventions aren't thought about enough. I think that in terms of developing these strategies further, actually, we've got to improve the health economic benefits of these sorts of interventions in selected patients, such that we get government funders, etc., and potentially insurers, depending on which part of the world you are, interested in developing these strategies. And there needs to be a lot more work there, both in terms of clinical research, but also, I think, advocating on behalf of patients to health services.
Okay, thanks for that. It's always the case, isn't it? You have to align economic incentives with and administrative incentives with science. Simon, what do you find most exciting about your ongoing or upcoming clinical trials, particularly any first-in-human drug or for that matter, diagnostic imaging studies?
Yeah, so I'm going to just specifically talk, I think, I would talk about, in the context of breast cancer early development, I think we're seeing some very interesting results from early phase studies looking at combinations of antibody drug conjugates and immunotherapy, particularly in the context of triple-negative breast cancer, which of course has traditionally still has a relatively poor prognosis. And an honest example to discuss would be the DASPOP deruxtecan durvalumab combination data that's been presented in the last year or so, where we're seeing remarkable first-line response rates and also quite a lot of durable responses. I've seen some of these because we took part in that study. So I've seen some of these in my own patients. But I know that a number of other pharma companies are looking at further studies of their own combinations, and perhaps not just the older checkpoint inhibitors, but also novel bispecifics in combination with ADCs in triple-negative breast cancer and other tumors. And I think there is a lot of potential in horizon scanning. I think there's a high chance that we'll see real improvements in outcomes in patients with both advanced triple-negative breast cancer, but also early disease.
Yeah. Then, of course, there's the whole discussion about, do you deploy your best agents at the beginning, or people talk about using them for rescue therapy. And, the whole health economics thing has to come into play, because invariably, if you treat the disease rather than price the drug, you discover that doing the best thing for the patients early is usually the best thing, right?
That has generally been the perspective. And certainly at the moment, a lot of these ADC, the ADC development program that AstraZeneca are running is looking at those first line and early disease settings as well.
So, Doctor, what have I failed to ask you that you would have hoped I might have asked you? And if I was thorough, can you give us a pithy take-home message for our listeners? So a two-in-one for you.
Okay, well, take-home message first off. I think we have to be a bit careful about some of the. There's a huge amount of information and interest in terms of dietary approaches in the context of cancer treatment, including breast cancer treatment. And that's completely understandable, because I think patients always want to work out what they can do for themselves. But the vast amount of information on the internet, etc., is impossible to sift through and understand properly. So I think that some simple messages about exercise and maintaining a normal weight are the ones that I always want to describe in clinic. Well, actually, I think you touched on that earlier. I think the GLP-1 agonists as a cancer preventative treatment. I think there's by reducing rates of obesity, perhaps selecting patients that might be at higher risk of the metabolic consequences of obesity and higher cancer risk. I think there's lots of potential interest there, and possibly even using it's really early days, but possibly even using these drugs in the context of patients with insulin resistance who have cancer, and whether that can augment treatment effectiveness, for example, in estrogen receptor positive breast cancer, as I described earlier. Would be an area of interest for me, anyway.
Well, watch this space, I guess. I always like to ask this question as a closer. If you came across a magical genie who could grant you 3 wishes for the future of breast cancer care, what would those wishes be?
Right. Well, I think we touched on some of these things earlier. So I think I'm really interested to see how the antibody drug conjugate immunotherapy combinations play out. I think I think there's a good chance that's going to lead to real improvements in outcomes for women with triple negative breast cancer. Another area I think of interest that needs more clinical data and translational data is understanding perhaps how we select patients with estrogen receptor positive breast cancer and HER2 positive breast cancer for immunotherapy. Working out if there are subgroups there that could benefit. We generally don't have good biomarkers in the clinic at all, of course, at the moment. And there also may be novel therapeutic strategies, for example, HER2-directed bispecifics that could come into play there. So I think that will be an interesting active area for research going forward. And then lastly, I'd say, we talked a bit about mammography earlier and cancer detection. Well, you mentioned mammography earlier. And I think it'd be interesting. There's a huge infrastructure course in terms of breast screening that's been developed that is enormously expensive to maintain, and whether with the advent of blood-based cancer detection assays, where all that cancer screening infrastructure will become the diagnostic infrastructure may not become redundant, but whether the breast cancer screening infrastructure becomes redundant that'll be interesting to see over the next decade or so.
Very much so. Well, unfortunately, that's all we've got time for, and I'd like to thank Dr. Simon Lord for taking the time and for sharing taking the time to join us and for sharing his insights and passions. And Simon, keep at it and help us treat this wretched disease. Thank you for your time, sir.
Great talking to you. Thank you.
And so, folks listening, if you're not already a subscriber, become one. Subscribe, Spotify, Apple Podcasts, all the other platforms. Leave a review, share it with your colleagues. It helps. And join us in a couple of weeks for another episode. Until then, I'm Dr. Jonathan Sackier. Thanks for listening to Onc Now. Please stay safe, stay well, stay curious. Bye for now. Well, I hope you enjoyed that episode of Onc Now, our bi-weekly podcast. If you did enjoy it, please consider subscribing on Apple Podcasts or Spotify or wherever you get your podcasts so you never miss an episode. And please like us on social media and tell your friends and colleagues. And check out our archives because they're growing. And please join us in 2 weeks for another fascinating episode. Until then, I'm your host, Dr. Jonathan Sackier. Please, everyone, stay safe, stay well, stay curious. Bye for now.